very much Team Reddy's who gave me an opportunity to be here to discuss one of the vague and one of the most complex and one of the most interesting right now in this post uh, in this time at around 8 p.m. to discuss about the role of potential role of gut microbiome in irritable bowel syndrome. See, if you want to talk about this irritable bowel syndrome, it is one of the complex entity to understand. So why it is very complex to understand? Because even in your daily practice, you'll be having complexity when you're going to manage. Even for the best of gastroenterology, will be having difficulty because what do you mean by irritable bowel? As per Rome 4 criteria, my session, I would like to make it very simple for everyone to understand in this area. So if any patient depends upon the age, even adolescent or adult, whoever the patient, if the patient is going to have a vague presentation of abdominal pain, if it is going to last for almost around 1 day every week, if it is going to be there, which is going to persist for almost around 6 months, and if there is going to be evidence of your abnormal defecation, as what I said, along with evidence of your change in frequency of stools and change in form of stools. It could be because of your irritable bowel syndrome type D, in which your lumpy stools, if it is going to be watery, it's nothing but diarrheal predominant. It could be constipation predominant. It could be hard and bulky stool. It could be mixed variant. Some days you may get constipation, some days you may get a diarrheal even, or it could be an unclassified variant. So based upon Rome 4 criteria, as what we have been recently using, it's to categorize this irritable bowel syndrome is very important. If you're going to look into that, it is a multifactorial trigger disorder. It is a heterogeneous disorder. And what are the pathophysiological, how the gut dysfunction is going to get happen? When you're going to examine a patient with this irritable bowel syndrome, you might not be able to identify. He might be normal, he might be having a coexisting diabetes, thyroid, or multiple components, obesity, metabolic syndrome, dyslipidemia, uncontrolled hypertension. So many coexisting comorbidities would be there. And when you're going to do an endoscopy and colonoscopy, it doesn't reveal any major abnormality, but this kind of patients will be having evidence of persistent abdominal pain for a longer duration of time without any significant benefit, which is going to happen even with multiple medication, and the patients will be going on for frequent doctoral shopping. What is going to happen? And finally, once the patient been referred to a gastroenterologist, how are you going to approach whether this patient deserve medication only to the GI tract or to control the brain and other abnormal pathway? Because you all should remember this irritable bowel syndrome multi-triggered hypothesis is that it could be because of your various pathways, it could be because of your sympathetic, parasympathetic, all those pathways, and various metabolites is going to get formed like your GABA, noradrenaline. So many mediators are there for this irritable bowel syndrome if you are going to get activated. And each and everything is having a potential role. How does it going to form? So the precise etiology as for this irritable bowel syndrome is what I said is unknown, but multifactorial origin is being proposed, and it could be because of your genetic factors, your epigenetic, your stress and nervous system, your endocrine system, your immune dysregulation, and these are all the brain gut. That's why it is also called as a brain gut brain syndrome. If your mind is happy, your gut is going to be happy. If your gut is happy, your mind is going to be happy. So why I would like to point out this picture, if you're not being, suppose if you're not getting good sleep, if you're overstressed, if your activity is not up to the mark, if your exercise and lifestyle modification is not up to the mark, if your diet pattern doesn't contain a low FODMAP pattern of diet, if you're going to consume highly sweetened beverages, there is high possibility for you to land up with this kind of multiple complication as the day progresses to you to develop irritable bowel syndrome, which will create a huge annoying event to the patient, and the patient couldn't able to carry out his routine activities. He couldn't go able to do the routine work, and he will be having frequent toileting most of the time, and most of the day he'll be spending the toilet. This is how the IBS syndrome is going to get worsened. So it could be not only because of your food hypersensitivity, it could be because of your toxins, it could be because of your adverse life events, it could be because of your chronic infections. or it will be because of your dysbiotic gut, or and all those things is going to predispose to this kind of irritable bowel syndrome, which is going to get happen. So why I would like to point out this picture, there are various players which is going to be involved in this pathophysiology of development of IBS. One is because of your alteration in your gut microflora, and one is because of that is gastrointestinal related tract, and by your dietary influence, your genetic factors, and your CNS system, which is going to get involved. What is the dietary influence which is going to get happen mainly by, if you're going to have a gluten sensitivity, if you're going to have a high FODMAP diet, there is high possibility for you to land up in this IBS related presentation. If you're GA influence, that's what is that? So main pathophysiology based upon your gut brain interaction, your visceral hypersensitivity, your altered gut metabolites, and psychological stimulus. These are all the things which will predispose to your variant, and this is the, that's how the intestinal influence is going to get happen. So the gut motility changes and low grade mucosal inflammation and immune activation is going to predispose. Your genetic and epigenetic factors is going to get involved. Your gene polymorphism and your methylation process, everything, if it is not going to be done in a proper manner, there is high possibility for you to land up with this kind of problems. And your central nervous system, that what I've been discussed with you on, by based upon your visceral hypersensitivity and your gut brain axis and your stress, these are all the components which is going to play a major role in the development of your irritable bowel syndrome. So the first and foremost thing you should remember about the basic pathophysiology, how does it going to happen, how does it going to manifest, that's how we need to understand. And what is going to happen if your gut microbiota, if it is going to get altered. So this is the main area for me to take on the discussion with you all. What is this microbiota? It encompasses the complex microorganisms. See, if you're going to discuss about the microbiota, it is going to comprise a separate system of your body. Now the microbiota, the terminology is being more in use right from your neonatal period, right from your intrauterine period to neonatal period, from your early neonatal to post neonatal, from infantile period up to childhood period and adolescent period, this complete area, and to the entire adult population. If the gut, it's not going to maintain eubiosis, and if the gut dysbiosis, if it is going to get established, there is high possibility for you to land up with multiple events. Not only for your GA disorder, it is going to take on with multiple other complications. For example, your cardiovascular, your neurological, your respiratory, all these. That's why the role of probiotics is being there for all the major conditions right now, which is being available. So once if your gut microbiota, if it is going to get disturbed, there are around 100 trillion of gut microbiota is there. And if you're going to remember about right from your uterine pathway, from triggers and various neurotransmitters and various growth factors, your immune cells, all those things is going to get involved. And the entire weight of this is almost going to around approximately 2 kilograms as of now, what being comprised, and 300 to 1,000 various species are being reported, and multiple factors. If you're going to look into that, multiple factors are going to be involved in regulating your gut microbiota. For example, your birth, the various drugs what you're going to take, whether you're going to born by normal delivery or by LSCs, or whether the breastfeeding has been established immediately or not, or what is the diet pattern, whether you're vegetarian or non-vegetarian, how the lifestyle modification, whether you exercise, your stress, your aging process, and so many other contributors are there for this gut microbiota to get established. So what is the density of this gut microbiota? So starting from your oral cavity and from your into your GA tract, the entire gut microbiota diversity will be having a very different population. So the maximum amount will be in your small bowel as well as in your large intestine. In the large intestine, in the distal bowel, will be having a maximum propensity. So you'll be getting almost around 10 power 11 amount of organisms will be there if you're going to look into your gut microbiota. That's why if any disturbances, if it is going to get happen, there is high possibility for you to land up with multiple complications like diarrhea and other events. That's why we need to maintain this gut microbiota without any complexity. even in newer conditions like alcoholic hepatitis and alcoholic liver disease and various malignancies, colorectal liver, inflammatory bowel disease, most of the conditions, there is a perturbance of this gut microbiota. That's why you are being landing up with multiple complications and multiple infections as the day progresses. Once a dysbiosis, it is going to get established. So this barrier, if it is going to get breached by your inflammatory mediators, and coming into the slide, like your intense immune reactions, your inflammation, if it is going to get happen, there might be evidence of changes in your gut composition. And what is going to happen, that I discussed with you, the gut modulators, if your integrity and altering your gut immunity and integrity pathway, modulating your gut-brain axis, which will be predisposing to dysbiosis, a condition that refers to a decrease or loss of microbial diversity and richness owing to the changes from common cell to pathogens. If you're going to look into various common cells, what are the various common cells? It could be in what is going to happen in your dysbiosis, the level of lactobacillus, the level of bifidobacterium, the level of firmicutes. It's nothing but Firmicutes plasmodium. If it is going to come down, that means the evidence of gut dysbiosis is going to get established. At that point of juncture, the patient may have worsening of your IBS. So your actinobacteria, your firmicutes, all these alterations will be predisposing to your gut dysbiosis. So once this bad bacteria, dysbiosis, if it is going to get established, so what is going to happen? And the epithelial barrier dysfunction, if it is going to get set in, that is the predisposing for trans-epithelial flux of multiple bacterial component is going to get intruded into your area, followed by the genetic defects and multiple mutations and defective immune regulation. Once a defective immune regulation is going to get activated, what is going to happen? It is going to act on your T cells and the effective T cell activation pathway, which is going to regulate your T regulatory cells. All these mediators will be predisposing to multiple events. For example, your IBS, your inflammatory bowel, all those cascade is going to be mediated by this one simple mechanism. What is supposed to remember? The dysbiosis, the epithelial dysfunction, your genetic mutations, and your defective immune regulation, which is going to predispose to this kind of mechanism as the day progresses. And how the gut microbiota, if it is going to get altered, for example, that's what I've been discussed, the lactobacillus and bifidobacterium are going to come down. And the recent study, what they've been mentioned in that intestinal microbiota signature that could be linked to the severity of IBS. So in this study, what they mentioned, the authors, that severity of IBS was being positively low CH4 exhale. That means the methane component is going to get exhaled, the low microbial richness and absence of Methanombacterium that shows evidence and enrichment of your various bacterial phenotypes. In this, that's how the mechanism in which your gut microbiota is going to get altered. And also you should remember that fungibiosis, now the term fungibiosis is also being there. The dysbiosis as well as fungibiosis, everything is going to be there. For example, if you want to alter the microbiome, and once the beneficial effects of probiotics on alleviating your visceral sensitivity, your intestinal permeability and inflammation, so which further support the role of your gut microbiota in IBS. So in IBS, as I discussed, the actinobacteria, the level of lactobacillus, bifidobacterium, and firmicutes, if it is going to go down, that shows evidence of worsening of events. So always you should remember that not only for your IBS, even for your SIBO, a small intestinal bacterial load. If the bacterial in your small bowel, if the bacterial load, if it is going to be there, that's why the role of antibiotics is going to be there. There might be evidence of GI motility if it is going to get disturbed, and your visceral sensitivity if it is going to get affected, your immune mechanism if it is going to get affected, as well as your bile acid pathway, your intestinal epithelial permeability. There are multiple events there to cause your SIBO. That's why the role of probiotics is being widely established, not only for this, as well as for SIBO, acute gastro, chronic events, your irritable bowel, your inflammatory bowel, not only for that, even in other non-GI disorder. That's how the role of probiotics has been taken over a clear lead when you're going to manage multiple scenarios in which if you want to improve, prevent the dysbiosis and to augment your eubiosis, that's how the mechanism of action is going to take on. And always you should remember the low-grade mucosal inflammation and immune activation. What is going to happen once the inflammation, if it is going to get set in? So combination of your mucosal inflammation with your visceral hypersensitivity, so it's going to impair your bowel motility. That could be an underlying etiology for your IBS, that what I will discuss with you all. So once it's going to happen, one that always you should remember in this recent scenario, a post-infectious IBS has been frequently reported. Initially, post-infectious IBS is more common with salmonella typhi infection, even for Yersinia, Campylobacter, Clostridium. So many infections are there which will predispose to a post. Now, even for post-COVID scenario, post-viral events, you are going to get a irritable bowel syndrome picture, that what we are frequently encountering right now in multiple population and during the initial period of COVID era. Now it has come down to some extent, but what is going to happen? Which stimulates is going to have an immune response, your aberrant immune pathway is going to get activated, and your mucosal inflammation is going to get set in. That's why it's going to predispose to multiple events, and followed by the bacterial, parasitic, and virus load is going to be low. That shows the evidence of your post-infectious IBS scenario is going to be there. Always, we should not forget about that. So microbiota, the role, how is it going to establish, as we discussed with you all, the post-infectious scenario, a SIBO, your altered colonic microbiota, and continuous antibiotic abuse. That might be evidence of antibiotic associated colitis, which will be predisposing to Clostridium difficile associated infection. And that's how the mechanism is there. And once a patient is going to have Clostridium difficile, you need to go for multi-line of therapy. It depends upon the severity, how the colitis is going to be there. And you need to go for either drug-based therapy, vancomycin, or sometimes you can go for fecal microbiota transplant as a patient is having severity of the colitis, if it is going to get established more. So I would like to point out always the lifestyle, your stress, your CNS factors, your immune dysfunction, your genetic predisposition, and if you're having an uncontrolled infection, which will be predisposing to you, your gut microflora, if it is going to get disturbed, which will have the epithelial cell integrity, if it is going to come down, there might be evidence of your diarrhea, there might be evidence of your abdominal pain to get worsened as the day progresses. That's what we should not forget. Your hypothalamic pituitary axis dysfunction, which will go to a psychosocial distress. If you have abuse, if you're having drug abuse events, if you have anxiety, if you're having evidence of depression, that shows evidence of your CNS disinhibition at that point of time. Your GA functions is going to get worse now. That might be evidence of your pain and diarrhea. As I wanted to discuss with you, the gut-brain events is going to get taken on. The dietary influence is very important for prevention of this IBS. So the low FODMAP is nothing but a fructooligosaccharides, disaccharide, inulin, all those things. Polyols, all those things has to be in a controlled way. So you need to follow a low FODMAP diet. And you can go for prebiotic, you can go for probiotic, you can go for symbiotic in management process. And this dietary influence, what way it is going to happen? A crucial role which is going to get in your IBS, mainly by modulating your gut microenvironment, thereby decreases your colonic fermentation and altered your gut microbiome composition and reduce your antigen activation by T lymphocyte activation. All those things is going to get reduced once if you're going to have a normal gut microenvironment. But if you're going to have a diet with high FODMAP or something else, what is going to happen? There might be evidence of microbiota dysbiosis, which will predispose to IBS. So the role of diet has been occupying a predominant role. The food and breakdown products of food can affect your gut in multiple ways, as I discussed, mainly by your altered motility, your permeability, your visceral sensitivity, your brain gut interaction, your immune functions, as well as your neuroendocrine function. These are all the 5 to 6 major components we are all not supposed to forget when you are going to manage a patient with irritable bowel syndrome. And this flowchart is very important. It's being given in multiple journals when you're going to look into that. So there's the gut-brain axis, what is going to get out. The ability of your brain to influence the intestinal microbiota, if it is going to get altered, the perturbation is going to get developed, followed by your physiology, your epithelial function, your mucin production, your enteroendocrine cell function. All these things is going to get altered. At that point of juncture, what is going to happen? your neural circuits is going to get activated, your immune response is going to get activated, your various metabolites going to get activated, which will predispose to a direct involvement of your brain by altering your hypothalamic pituitary adrenal axis. That's why the various pathway like your cytokines, your microbiota, and all those things, if it is going to get involved, thereby the perturbation is going to get happen at that point of time. And once if any of these barriers, if it is going to get involved in that, that might be a clue for the possible event of this gut-brain syndrome to develop. So as the day progresses, if the patient is going to have any neurodegenerative disorder or any gastrointestinal disease in which the patient is going to develop this kind of presentation as the day progresses. And how are you going to differentiate based upon your bacterial load? If you're going to look into for IBS from IBD, the predisposition. So if you're going to see the actinobacteria, firmicutes, as well as bacteroides is going to be too high. If you're going to see in IBS population, this is going to come down. In IBD population, the bacteroides ratio, if it is going to come down, the good bacteria, if it is not going to get formed well, that might be high evidence for this patient to predispose to this IBS from IBD, IBS and IBD like presentation. So as you all know, IBD is a vague IBD is a terminology in which it encompasses Crohn's as well as your ulcerative colitis, in which the causative agent cannot be able to identify because of your immune dysregulation, because of your gut dysbiosis, so many other etiologies. That's a separate area for us to take on the discussion. But if you want to remember that how the microbiota is going to get disturbed mainly by your actinobacteria, firmicutes, your bacteroids, your plasmodium, all those things we are not supposed to forget when you're going to target your management in irritable bowel syndrome. And the most common presentation will be the patient will be having bloatedness, your bloated abdomen, your distension of your stomach, as well as a high flatulence. Your gasiness will be there. Some patients may experience diarrhea alternating with constipation various days, and you may have fermentation by production of gases. Methanobacteria brevis is high possibility for this kind of patient, and high methane production could be there, and thereby evidence the effect on transit and bile acid metabolism. It's also going to get involved. That's how the mechanism of your gut dysbiosis is going to get established, and by the IBS symptoms is going to get worsened. And SIBO, as I've been discussing with you all, SIBO you can easily diagnose by multiple modality by either your breath test, or you can directly identify through your jejunal aspirate. Once the white bacterial load, if it is going to be more than 10/5, that might be evidence that the bacterial overgrowth is going to be there. And why I would like to point out this picture before you're going to consider the patient for rifaximin, another line of support, you need to diagnose, you need to look into the clinical picture. If the patient is having post-surgical event, there might be evidence that the patient is going to land up with evidence of small intestinal bacterial growth. So before labeling them, we can do any of the tests, and we can able to identify, we can able to differentiate whether it is only a SIBO or coexisting SIBO with IBS. All these presentations can be controlled only by doing this kind of investigation for the patient who is going to land up with this kind of presentation. And there are various studies in which various papers from 2015 to 16 being reported, and the various tool collection, your microbiota. And the one important thing is genomic analysis, like 16 years ribosomal RNA, in which you're sequencing, if you're going to do, you can able to identify, and cytolethal toxins you can able to identify if you want to look into this various causative phenomena, causative organism, if you're going to diagnose. So why I would like to point out this picture. So what is going to happen? The microbiota and IBS severity. In this, as we have discussed, the high genomic sequence, if you're going to get formed, you need to identify your microbial richness, your exhale methane levels, your methanogens, and as well as your enterotypes like your clostridials as well as Prevotella. So through your genomic sequencing, if you want to identify your gut dysbiosis, and you can identify through these mechanisms, you can identify your SIBO by your jejunal aspirate, and you can identify by your breath hydrogen levels, and as well as we can look for, based upon your 16S ribosomal sequencing, what are the organisms which is going to get predisposed. We can have a look on that for your severity to be identified. This is how the switching mechanism, as what have been discussed, been reported based upon your various IBS subtypes in IBS-C, IBS-D, and IBS mixer. And this is how the archaeology, if it is going to get disturbed, and the IBS severe enterotypes, if you're going to see here, it could be Clostridium or Bacteroides or Probiotics, if it is going to get disturbed. And this mechanisms, if it is going to get activated by your microbial richness, there is high possibility for you to land up with this severity. And significant impact of probiotics. So briefly about your probiotics, it could be based upon your ESOs, or it could be because of based upon your lactobacillus or bifidobacterium or Saccharomyces boulardii, whatever the source you are going to use. You need to target the clinical presentation, and you need to choose a strain in which predominantly single strain, it doesn't cost to be much of a reasonable immunogenicity, and the bacterial adhesions pathway should be good. The defense mechanism should be good when you're going to use your probiotic. So the various, it has to be a T cell mediated, and it to be a T helper cell mediated, and it could not, I mean, all those things to be involved when you're going to target a probiotic. So what is that probiotic? It's nothing but if you're going to give some microorganisms in which it's going to get a beneficial effect to your host population. And prebiotic is nothing but undigestible sources. Undigestible carbohydrate, it could be a unilane, it could be because of your fructooligosaccharides, or it could be a combination of fructooligosaccharides as well as your inulin. So why I would like to say, if you're going to use a probiotic based upon your GA symptom of abdominal pain, your bloatedness, your flatulence, that shows evidence, that shows some impact, that might be having a significant beneficial ratio when compared to your placebo. So you can consider probiotic as a systematic review if you're going to look into that. And one important thing before concluding, I would like to show you all about your FMT, fecal microbiota transplantation. Fecal microbiota transplantation has initially been well established in the management of antibiotic-associated colitis, in which from the donor, if you're going to centrifuge a stool sample and you're going to inoculate into the recipient. So this methodology doesn't have major adverse events as of now. From 2013 onwards, you have been trying that fecal microbiota transplantation, initially from Clostridium difficile, and right now up to alcoholic hepatitis. There are various conditions in which you are going to use, say, FMT. If you're going, so you need to centrifuge 50 to 100 ml of stool samples. You need to centrifuge, and followed by you need to infuse into the patient and the recipient. How are you going to do that? You can do either by an endoscopy, or you can do either by a colonoscopic approach. You need to place in the small, you need to place in based upon that, we need to look into how the fecal microbiota transplant is going to respond to a patient who is having irritable bowel syndrome. And there might be multiple papers being there, but how far it is going to be established, how far it is going to be successful in India, that still we need more and more papers to validate this statement. And before concluding, what I would like to point out to you all about this gut microbiota, we should not forget, and gut disturbances, if it is going to get established, if your gut dysbiosis, if it is going to get formed, and there is high possibility for you to land up with multiple events like your cardiovascular, allergic, respiratory, and mainly your GI disturbances like your acute to chronic GI disorders, and it predisposing to IBS to IBD, and predisposing to a antibiotic associated colitis. And the role of probiotics has been well established in the management of irritable bowel, along with your fecal microbiota transplant. And we need to maintain, do good physical activity, control of metabolic syndrome, and control of thyroid status, control your dyslipidemia, control your diabetes, on all those proportions if you're going to manage. And you need to target your gut eubiosis. If it is low FODMAP diet, the diet pattern should be well established. And once a clinical presentation has been augmented, we need to report to the gastroenterologist as early as possible to overcome all the complications successfully. With this, I'm happy to rest my presentation about this role of probiotics, the role of gut microbiota in IBS. And if any questions is there, you can proceed with that. Thank you all for patient listening.
Thank you so much, sir, for your wonderful presentation. Technical team, is there any questions?
Hello, sir.
Can you please
Yes,
read it out?
Yeah, just give me a minute, sir. I'll check if there are any questions posted and I'll let you know. Hello, sir.
yeah.
Yeah, sir. There are a couple of questions posted in the chat box. Can you see the Zoom chat box? I have copied and pasted all the questions from the attendees in there. Please have a look at it, sir.
Where is the chat box? I'm looking into that. If you don't mind, can you please read the questions?
Sir,
Yes.
can you click on the more options?
Yes, sir. I will read it, sir, for you.
Yeah,
More
fine.
options I have clicked.
Yes.
Please go ahead.
Yes, yes. Sir, I will read it, sir.
Yeah.
Yes, sir. The first question is, do one need to take a prebiotic therapy after oral antibiotics?
Prebiotic or probiotic, sir?
Do one need to take a prebiotic therapy after oral antibiotics?
See, depends upon what condition we are going to treat, depends upon whom we are going to treat, depends upon the clinical presentation, what is the illness we are going to treat, all those things decides. And all the patient who are being treated with antibiotic doesn't mean that the patient deserves a probiotic or prebiotic support. Because your natural system, your immune system, that's what I've been discussing with you all. Once your gut disturbance is going to get established, as we all know, your clinical presentation is there to take on. Once a natural immune system, your T helper cells, your T cell response is going to be get well activated. Even if you're going to get an antibiotic, doesn't mean you need to take a probiotic or prebiotic always. So based upon your clinical presentation and to whom you're going to treat, those are all the major things. If you want to discuss, it's very, very important. But there are some antibiotics. For example, your antibiotic associated colitis like your ampicillin, tetracycline, your lincomycin or clindamycin, and there are so many even for third generation cephalosporins when you're going to consider at that point of juncture, if you're going to use for a longer duration of time, you may consider probiotic support, but always based upon the clinical symptoms and management you need to consider. Not just like that we need to start on. Any questions?
Thank you, sir. And second question is, how to assess if a patient has dysbiosis, and once a probiotic is prescribed, whether the dysbiosis is taken care of or not?
Based upon your clinical response, but that's what I've been discussing with you all. When you're going to manage a patient with irritable bowel syndrome, it is not only based upon your gut dysbiosis. Irritable bowel syndrome, as of now, the causative agent cannot be identified perfectly. It could be a multifactorial, it could be a heterogeneous disorder. That's what we're discussing. So a multifactorial event doesn't mean if you're going to tackle with a probiotic, it's going to respond. How the patient is going to be there, how the patient's psychogenic stress is going to be there, what is the coexisting comorbidity is there for the patient, how the diet and lifestyle modification is going to get well established, how the patient is going to adhere to the low FODMAP diet. These are all the pointers you need to address and you need to manage how the neurological component is going to be addressed. For example, your various neurotransmitters like your what have been discussed like norepinephrine, your GABAergic pathway, these are all the various mediating metabolites is going to get involved in your IBS. So how do you target all these things? How the neurological function is going to be taken care? What are the medications you are going to use? And how are you going to have a serial follow-up? What are the other coexisting presentation? Based upon all these things, you need to manage a patient. And doesn't mean once you start a probiotic, the patient is going to respond. And if you're going to think like that, most of the patients will not improve for any this kind of presentation. Probiotic is just to support, and your clinical approach matters a lot when you're going to manage a patient with irritable bowel or inflammatory bowel or small intestinal bacterial overgrowth.
Thank you, sir. And next question is, role of probiotic in fatty liver.
Role of probiotics in fatty liver is definitely a reasonably, it's not up to, if you're going to think about that, the role of probiotics in fatty liver, there are various papers to report, but the beneficial effect is still a questionable role. But even in role of probiotics in fatty liver, we can consider, and based upon your gut dysbiosis, if it is going to be there, and like alcoholic liver disease, there is high possibility for you, because not only based upon your folate and other pathways, based upon your aldehyde and other pathways, even for your bacterial permeability, your PAMP and DAMP activity, if it is going to be there, that's nothing but a pathogen pattern, as well as your molecule and your damage associated pattern. All these things, if it is going to get disturbed or perturbed at that point of juncture, you can give probiotic in fatty liver. But isolated fatty liver, the role of probiotic, it's not been well documented, rather than diet, lifestyle modification, because fatty liver disease is mainly for the person who are having lack of exercise, uncontrolled diabetes, and all those proportions population. So once the patient, if it is going to take on with diet and lifestyle modification, with few line of medication, what we consider like the tocopherol and all those things, apart from that, there is no significant beneficial role of probiotic in fatty liver disease.
Yes, sir. Thank you, sir. And the next question is difference between bacterial and yeast probiotic, and your preference as per your experience.
Bacterial, that's what we have been discussing. Oh, what are the conditions you are going to get targeted? If you're going to look into the various organisms, so various articles, Saccharomyces boulardii, and if you're going to look into the Lactobacillus rhamnosus GG, they have been various compared. For Lactobacillus rhamnosus and peptic ulcer and other diseases, that might be having a significant potential role. For lower GI pathology like irritable bowel, Saccharomyces boulardii is yeast-like extract is going to have a significant beneficial role when you're going to consider in the management guidelines. So based upon what are the events you're going to get target, in which area, because if you're going to look into the bacterial diversity, starting from your oral cavity to your anal canal, and in the distal bowel, the bacterial diversity population will be almost around 10 power 11, but in the proximal it will be only 3, 10 power 3, 10 power 5, like that. So as a patient is going more to the distal, out of the organisms, it could be because of huge list. If you're going to look into the microbiota, it could be because of batrons, it could be because of firmicutes, it could be because of other anaerobes, it could be because of Clostridium. So many huge lists are there. So what are the things, what are the presentation, what is the area you're going to get target? Based upon that, you can consider your yeast or your battery-based therapy. But main thing, based upon you for your IBS, the yeast-based probiotic is going to have a reasonable beneficial role when compared to other that.
Thank you, sir. And the next question is safety aspects of probiotic after prolonged use.
After prolonged use of probiotic, the safety concern is not much of any major adverse events being reported, but some vague papers been reporting evidence of other mild renal injuries and other complications, rare complications being reported, rare events of some GA diarrheal events. Also, some patients may have been reporting with worsening of event, but these are all not major significant potential adverse events being reported. But mainly, when you're going to use prolonged dose of probiotic, no major significant adverse events apart from what I've been discussed with you all.
Thank you, sir. And the last question is, please mention the FDA approved indication of microbiota transplantation.
The approved indication for microbiota transplant right now, being more papers being done. That's what is what you're going to say is antibiotic colitis, nothing but Clostridium difficile colitis, in which you are going to donate to the recipient your donor sample. You are going to centrifuge either through your upper GA or through your lower GA, either through your endoscopy or through your colonoscopy. You are going to retain the stool for a duration of time, and that's how we are going to assess the response. For antibiotic associated colitis, definitely having a potential role with this FMT as multiple cycles are progressing. But how far it's been more validated in India, how many centers have been doing that, it's still a questionable issue to be addressed when you're going to manage with FMT in gastroenterology.
Thank you so much, sir. That was the last question. Thank you so much, sir, for your wonderful presentation on this topic today evening. And I would like to, on behalf of Dr. Dis, I would like to say thank you for your valuable time spending with us.
Thank you very much. Thank you, Team Reddies, and thank you for all the delegates for being here. Thanking you all for patience.
Thank you, sir.
Thank you.
Hello, sir.
Yeah.
Ma.
Yeah. So, sir, with your permission, shall I end the meeting?
Yeah, sure. Thank you very much for all the technical team who will be here. Okay.
Thank you so much, sir.
Thank you.